Good afternoon, everyone, and welcome to the webinar on lung recruitment in the OR and ICU by Dräger's John Barrett and Christian Bozsak, the marketing managers for the AAA in anesthesia and OR. I think we'll wait possibly another 30 seconds before we go to the next slide and go through the agenda and some of today's, go through the script before some of today's webinar.
Our side, thank you for the introduction. We are very excited to talk about lung recruitment in the OR and in intensive care.
Yeah, welcome everybody. Thank you for giving us some time. We really do aim to make it fruitful and worthwhile, and we do welcome questions. If you could please pop those in the chat, and we'll try to get to those towards the end of today's webinar. Welcome everybody from wherever you are. Hope you're safe and well.
So I think we might make a start, just some reminders and some housekeeping. Before we get started, I'd like to go over the session features and some housekeeping. Firstly, you will find if you're having any audio or video issues at any time during the webinar, please disconnect and reconnect. This should solve the problem. Also, we will be muting your mics today to reduce any background noise. Disclaimer-wise, this is for information purposes only and does not replace the IFU or instructions for use of the retrospective devices. Finally, I'll go through the agenda. So next slide. So our agenda today will be looking at lung recruitment as an overall. We'll be looking at lung recruitment in the OR, lung recruitment in the intensive care, and image-guided lung protection. I'll now hand over to our first speaker, Christian, but just before I do so, when it comes to questions, you will have an opportunity to submit questions by typing your questions into the questions section of the control panel, and our speaker will answer them during the Q&A session at the end of today's presentation. If there are any questions that we deem the need to answer during the slide, we'll try our best to do so. Otherwise, I'll hand over to our first speaker, Christian Bozsak. Over to you.
Thank you very much. Warm welcome. Let us begin. We are excited to have you here. We would like to share with you our strategies on how to improve acute care. And this is our mission. This is what we are here for, to talk about strategies. How can we improve outcome both in the OR and in the ICU? We have actually several different tools available. We will mainly focus on protective therapies. So how can we support the clinical effectiveness? But you will actually see that also other parts of technology might be mentioned, going into technologies which are connected. So bringing several devices together, talking about care-centered workplaces as well. But the main focus for today is protective therapies. How can we protect the lung both in the OR and in the ICU? So the topic of today is lung recruitment. What is lung recruitment? What are we going to talk about today? We all know that lung recruitment is a process which requires an increase in pressure. We are trying to inflate previously collapsed alveoli to restore FRC, to improve oxygenation, improve ventilation. So we need to open unstable airways. And of course, at the same time, we are trying to make sure that we are doing this in a safe and secure manner. When we look at the different strategies comparing ICU and OR, in the ICU, we have different tools available. We could be talking about sustained inflation or incremental, decremental PEEP trials about size. In the OR, as of today, still the bag squeezing is one of the most common ways how to do lung recruitment. But of course, we're going to talk about more advanced measures in our OR section. So let's have a look right here. We have a look right now at a mandatory ventilated patient in supine position. So as you know, even the fact of intubating a patient, relaxing the patient, of course, leads to a shift in the distribution of air inside the thorax, inside the lung. We see, of course, with relaxation, the position of the diaphragm is changing. We're going from an active push and pull of the diaphragm towards actually handing over the work of breathing to the mechanical ventilation device, be it the anesthesia device or the ventilator. So we will see that the diaphragm and also gravity itself already play a very important part in causing atelectasis, which then needs to be rectified with lung recruitment. So just looking at gravity, it's clear that we have different areas. I mean, this whole concept is based on the 3 zones of West, as you know. So we go from independent to dependent regions within the lung. So independent parts of the lung more on the ventral side, and then the more dorsal you go, you see then having the dependent parts of the lung. So just by this gravitational distribution, we have regions inside the chest which are in risk of overdistension and other regions which are in risk of atelectasis. So even though we will be focusing mainly on lung recruitment, talking about atelectasis and how to reverse atelectasis, of course, at the same time, we always need to be careful and look out for potential overdistension. So here we can see this then in real life, what I just explained in just a very simple approach. The diaphragm, gravity. So this is just a lateral chest X-ray showing, I would say, a very severe case of dorsal atelectasis. So this is really where we're going to start. This is how we want to jump in. So in order to understand how can we talk about atelectasis over distension, we need to have a look at lung mechanics in general. We want to see how does the lung behave. You can see now in this picture, you can see an overview from an animal model. You can see in the first row inflation, and in the second row you can see deflation. So during inflation, we are increasing in this animal experiment the airway pressures from 0 to 4 to 8 to 12 to 16. So actually, what you see in the first row, that inflation of this animal lung only happens, around an airway pressure of 12 or 16 even. And then during the deflation side, you can actually see that when we are going down in airway pressures, the lung remains open for a longer period of time. So when we are, for instance, comparing an airway pressure of 8 millibar during inflation, we can see that actually the lung is still collapsed. However, once the lung has been opened, it remains open even at an airway pressure of 8 millibar. This is how we can see really in a very good example. We can see the hysteresis of the lung, the different behavior during inflation and deflation, and showing us the difference between an opening and a closing pressure. And we will come back to this very basic understanding again and again throughout the presentation. So this is why we really wanted to start with these fundamentals and this understanding of lung mechanics, how to open a lung, how does it behave, and the difference in actually history of pressures.
Excellent. Thank you, Christian. And that's the core of what we're also trying to achieve when it comes to lung recruitment in the OR. A lot of atelectasis that you encounter in the OR will obviously be very recently introduced, which gives us a significant advantage. We've already talked about improving clinical outcomes as something that Dräger are very focused on. We really believe that lung protective ventilation is a way in the OR that we can help clinicians achieve these improved clinical outcomes. We know that in the developed world with modern equipment, there is still, at least 5% of patients surgically having some sort of postoperative pulmonary complication. And then, from that, there are some dangers that we need to face. So with Dräger devices, we're both focused on the quality of the device, but then also the ability to be able to train and support clinicians to achieve those clinical goals. And, to do that, we need to be able to give you information, and we need to be able to provide training and support to help make those informed decisions. That comes down to, installation support, training, webinars like this, but then also what information is available on the device to make informed clinical decisions at the acute point of care, both from an analysis point of view about what's going on with your particular patient's lung, to support low and minimal flow anesthesia, or even to support drug effect supervision with products like Smart Pilot View. Why does Dräger care about this? Well, the clinical relevance is that 5% of patients, as we said, still suffer from some form of post-operative pulmonary complications. 20% of patients who develop a PPC die within the first 30 days after surgery, and there's a 70 times higher risk of mortality for any patient who requires post-operative reintubation. And this is certainly something we really wish to avoid. And of course, we need to look at all of the different factors that go into lung protective ventilation, and today we'll focus on lung recruitment. Why does it matter? Well, of course, improving outcomes is incredibly important for each and every clinician. It's something that Dräger really do want to support, but also when it comes to managing the cost of care in these really challenging and difficult times that we've all faced in the last 18 months, there is a significant cost impact that comes with having a patient have a post-operative pulmonary complication. There's a couple of studies out there, and a meta-analysis of that has shown that the potential cost within the developed world of a PPC is something around 82,000 euro, or around about 83,000 US dollars per operating room. So if your hospital that you're in has 10 operating rooms, that's potentially, roughly €1 million a year, 880,000 euro a year. So that's certainly something that's going to help impact, the cost impact, or help reduce the cost impact on the healthcare system, which is significantly under threat. Christian's already gone through, the effects of mechanical ventilation. We know that by sedating, paralysing, and having a patient lie flat on their back on the operating table, it's going to cause some potential for both atelectasis and, of course, also then potentially cause potential for barrier trauma if we don't get our settings right for the individual patients. What are the global clinical recommendations? Now, this comes from, the anaesthesia societies, both in Europe and the US, and across Australia and New Zealand and the region. There's a lot of data and information out there to support these recommendations. These are most certainly not Dräger's recommendations. These come from, the global societies that support lung protective ventilation in the OR. They're targeting tidal volumes of 6 to 8 mils per kilo of predicted body weight. So not actual body weight. It's about keeping plateau pressure quite low. So that goes against the idea of actually doing recruitment manoeuvres. But, keeping your driving pressures low and keeping your plateau pressures low is going to be challenging in some circumstances, particularly if you've got a belly full of CO2 and a head down approach for surgery for 3 or 4 hours. Spontaneous breathing as often and as early as possible in every case, keeping your FiO2 quite low. A low FiO2 will help reduce the incidences of atelectasis. And PEEP, while still a little bit controversial, and there's still a lot of strong discussion around it, moderate to low PEEP, so somewhere around 5, or maybe a little bit more, and certainly talking about individualized PEEP, which we'll get into a lot more later on in this chat. Recruitment is obviously still under discussion. It's obviously not something yet that's accepted as being required in every single patient, and there's certainly no recommendation that every patient should have some form of recruitment. But there's a lot of data coming out, and there's a lot of study and research going into proving the validation of PEEP and the Improved 2 trial, which we expect to come out quite soon. If it's not already done, we'll actually look into recruitment manoeuvres a little bit more deeply. And of course, low and minimal flow anesthesia has a great lung protective ventilation effect by keeping the airways nice and moist, and also great for the environment, as we know. So, how do we support effective and low tidal volume ventilation? Well, a lot of modern devices can actually be pre-configured. So if you put the patient's height into the device, then the device will actually then give you the ideal body weight. It'll calculate the ideal body weight for you, and then give you pre-configured tidal volume setting to match that patient's ideal body weight. So look into your device, look into your configuration, make sure that your anesthesia device can actually give you predicted body weight, and then also have your pre-configured settings come out for that particular patient's suggested body weight. Of course, we want systems, we want anesthesia devices that have a very friendly compliance and very low compliance, and actually even have dynamic compliance compensation. A lot of your modern anesthesia ventilators will allow for dynamic compliance compensation. Of course, we want these patients to not have to fight the ventilator at any stage. PEEP, we've talked about as being quite important. There's no point in opening the lungs unless we keep them open. So selecting the right PEEP for your particular patient really does matter. But of course, then if you set that PEEP on the device, you want to know that it's accurate and that it will actually still deliver effective PEEP even in the presence of leaks. This is particularly challenging when it comes to patients where you have an LMA. So you want the LMA patients to be spontaneously breathing as soon as possible, and you want the PEEP that you set to be delivered by the device even if there is a leak. The modern anesthesia devices that we are talking about today, particularly from Dräger, have active PEEP compensation even in the presence of a leak. So the piston in the Atlan will actually continue to move to ensure that the PEEP that you have set is maintained, and the turbine in the Perseus, which we feature more today, actually just spins faster in the presence of the leak to ensure you are getting the PEEP that you have set. And this is very important when it comes to lung protective ventilation, of course. There's no point in setting a PEEP unless you're able to deliver it for the full expiratory cycle. On top of that, you want some information to be able to help you make these decisions, of course. Now, on the devices that we're looking at and thinking about today, a lot of modern anesthesia machines have fantastic information they can display on the screen. A couple of things that we'll focus on in particular are your delta tidal volume. So looking at your inspiratory versus your expiratory tidal volume, and then giving you your delta tidal volume, therefore what your leak is. That'll help you set a really effective tidal volumes, but also give you an understanding about what's going on from a fresh gas point of view. And of course, compliance is particularly important, and looking at the dynamic compliance, breath to breath of your patients isn't probably going to help unless you actually do have a trend. So the devices we'll be looking at today, the Perseus in particular, has a wonderful dynamic compliance trend for you to be able to look at that dynamic compliance over a longer period of time, and then make some decisions about what actions need to be taken, if any at all. Of course, we talked already about low compliance and spontaneous breathing. The best form of lung protective ventilation is spontaneous breathing and pressure support ventilation, if you can achieve that. And also in your volume mode autoflow or your pressure guarantee modes of ventilation, you want to be able to deliver spontaneous breaths when the patient requests that, and be able to deliver them with pressure support ventilation and effective and active PEEP to reduce worker breathing. So you need a really good responsive trigger. You need a high trigger sensitivity. You need to be able to adjust your trigger sensitivity to suit your particular patient, and that's all available on a lot of modern anesthesia ventilators. On top of that, for particularly tricky patients, for particularly difficult patients, for patients who come through ICU, you may want to go a little bit deeper and have a look at some more lung monitoring. So actually having loops and dynamic compliance and breath-by-breath compliance monitoring is going to be very important. Of course, then you might also want to link that with your patient monitor and to be able to do some analysis, which we'll have a little bit of a look at later. You might want to save a reference loop at the beginning of your case and then track that patient's loop throughout your case, and that'll give you some indication as to what's going on with that patient's dynamic compliance. And then we come to the meat of the talk, talking about lung recruitment. So lung recruitment's possible with every anaesthesia device, particularly if you've got the ability to be able to set in your pressure control ventilation that your peak inspiratory pressure changes as you change your PEEP. So with that pressure control ventilation, you can actually do a stepwise increase of PEEP and peak inspiratory pressure, or you can actually just increase your PEEP if you don't want to change your peak inspiratory pressure. So there's a lot of different ways that you can actually use an anaesthesia machine without automated software in particular. And you can do this while you're looking at what's going on with your patient's compliance and trying to make some assessment of what's happening with PEEP and where their optimal PEEP is. Of course, you're also looking at your FiO2 and you're looking at your gas exchange. So we've got a few other tools that you might want to consider, like your minute volume and your CO2 production, or your O2 uptake, all of which you can discuss with your device representative as to which one you'd prefer. Now, lung recruitment in the OR, as we said, still a little bit controversial, still a lot of discussion going on. And I'm not sure if you're discussing this within your own particular department, but certainly, at a lot of the major global conferences, be it all virtual these days, there's still a lot of research being presented. And we've, got some very famous names from the ventilation world and from the anaesthesia world: Grasso, Habashi, Petroni, Lim, Pelosi, etc. There's a lot of information out there, guys. And, we really want to think about what the latest recommendations are. There was a fantastic talk at the European Society of Anaesthesia Congress in 2019 that we were lucky enough to get to before the world went mad, where Foutier, Pelosi, and Gamma actually did a talk on what is the latest research and what the latest global recommendations are. And they were very much for a recruitment manoeuvre in the OR. And there's a lot of high quality supportive evidence lacking, but there is still very much a trend in the evidence that we've got towards recommending a recruitment manoeuvre. Now, bag squeezing should be avoided in favour of a ventilator-driven recruitment manoeuvre. The focus really is on the safest way to be able to deliver an automated recruitment manoeuvre. The recommendations around what your lowest effective, plateau pressure should be is somewhere between 30 to 40 centimetres of water for your non-obese patients, and something like 40 to 50 centimetres of water for your obese patients. And of course, the shortest effective time or the fewest number of breaths to actually see something change or something happen within that particular patient. Always continuous hemodynamic and oxygen saturation monitoring. We'll talk about that a little bit further later, but keeping an eye on what's going on from a hemodynamics is obviously very important. The lungs and the heart are very much in the same cavity and do have an impact on each other. And PEEP should be individualised following a recruitment manoeuvre. So, we'll look at actually how you might achieve that individualised PEEP a little bit later. Is there any particular evidence to say that it works? Well, of course there is. There's from that same group that did the talk at ESA in 2019, there's a really good article that looks at lung protective ventilation for surgical patients. An international expert panel discussed it and then brought out a consensus of recommendations, which is where the global recommendations are actually taken from. And on the right of the screen here, you'll actually see just how weak the evidence is towards supporting what those claims are. And of course, that means that these global experts are looking at ways that they can improve that strength around the quality of the evidence. So a lot of the evidence looks at short-term gains within, the OR or the hospital. It doesn't really look at long-term morbidity and mortality, and there's not a lot of evidence yet that recruitment manoeuvres intraoperatively actually support a reduction in morbidity and mortality, but there's very clear links to a reduction in postoperative pulmonary complications, shortened time in the recovery, shorter days staying in the hospital, and certainly much less incidence of reintubation potentially. So have a look at these. They're all available widely. I mean, Prove High-Low is one of the most famous recent articles from the Prove network, who have also done Improve and they're doing Improve 2, and all of these are actually looking at particular outcomes around recruitment manoeuvres and other lung protective ventilation topics. There's educational videos out there. Not all are great, but there are some on YouTube, if that's your preferred channel to going for education. There's a lot available even within Australia, done by Australian clinicians, and even some by Australian anaesthetists, looking at lung recruitment and the value and the quality of lung recruitment and how to perform it. Here's from those recommendations then what's able to be done on a number of modern anaesthesia devices. Of course, we'll focus on those manufactured by a German company called Dräger, for whom we work, and we want to really just focus on what we talk about with automation from a recruitment manoeuvre point of view, and what's available to actually make it both safe, simple and easy to use, and easy to do. And we'll have a fantastic video that we'll present that Lynn put together. So there's just the very basic approach of increasing PEEP. You see you've got some challenges with that particular patient. You've maybe got a little bit of a reduction in dynamic compliance, and gas exchange may not be where it's ideal for that particular patient, and you can just increase PEEP. And most anaesthesia devices will do this and do this effectively and do this well. And then you've also got the bag squeeze or the sustained inflation. Now, you can do this manually, but as you can see from the global recommendations, they prefer and they recommend strongly that you actually use an automated system on a modern anaesthesia devices, and a lot of machines out there have this option. So you just set your 30 for 30. You can actually do it within ManSpon, or you can do it from any one of the ventilation modes. And then, of course, the pressure pyramid is the gold standard. It's the preferred and the most recommended by clinicians who've looked into it. And the pressure pyramid, or the stepwise recruitment manoeuvre, which we'll go into a little bit, is possibly the most effective, because it helps find that individualized PEEP you're looking for. So how do we set the pressure and the duration on a modern anaesthesia device to be able to deliver a bag squeeze? It's pretty simple. On the Dräger device, you go to Procedures tab, you set your 30 at 30, and you press Start. So here's where you choose your pressure and you choose your duration in seconds. You can set a reminder to do it, again, an hour or 2 hours into the future, and you hit the Start button, and then away you go. Of course, if you need to cancel at any time, you can. If you want to do a bag squeeze, have a look at what happened with the patient, try and pick where the optimal PEEP was, do a second sustained inflation, and then press cancel. On the Perseus machine, you can then actually configure your PEEP before you actually cancel that particular recruitment manoeuvre. For the incremental PEEP, or the stepwise, or the pyramid, there's a little bit more that you need to set and a little bit more that you need to think about. Of course, you still set your maximum pressures, so your maximum peak inspiratory pressure and your maximum PEEP. You can then set a number of other parameters, your delta pressure, your breaths at the maximum, your breaths per step, and you can also set a reminder. What are we talking about when we talk about breaths per step? Well, it's affected by your respiratory rate. It's the peak inspiratory pressure goes up, as does the PEEP. At your delta pressure that you've got pre-configured, it will then take 1, 2, 3, or 4 breaths at that particular PEEP and peak inspiratory pressure, and that's your breaths per step. Your breaths at max is the number of breaths that it will take when it hits your peak inspiratory and peak PEEP max. And then, of course, you'll get this pyramid stepwise feature on the patient's peak inspiratory pressure and PEEP curve. Of course, the best way to find optimal PEEP is to do a recruitment manoeuvre, go back, review that recruitment manoeuvre, and then do a secondary recruitment manoeuvre and stop that secondary recruitment manoeuvre when you hit the cancel button, and then set the optimal PEEP. And we'll talk a lot more about optimal PEEP in the coming hour or so. The nice thing about the device that we're featuring today, the Perseus, is it gives you that ability with a cursor to be able to go back and look at where your potential opening pressure might have been by keeping an eye on your dynamic compliance and your PEEP. You can adapt your PEEP then and restart the procedure, and Lynn will show you what that looks like in the video. If you have your device teamed up with a modern patient monitoring system, modern workstation from Dräger. We also have on the Infinity Acute Care Monitoring System the ability to use the analysis tool on that system. And this gives you a lot of information, both from a hemodynamic point of view to support, that vigilance around hemodynamics, but also to look at potentially where your optimal PEEP or your opening and closing pressures might have been. And that will support, your clinical decision making. Of course, needing modern connected devices also gives you the ability to be able to send that information, to be able to potentially then review that and even do some studies on that. So we really want to support clinicians in that access to data, and a modern anaesthesia device from Dräger with Dräger monitoring will certainly help support that. On those tools are also a lot of other decision support materials or decision support opportunities, not only looking at what's going on from a lung point of view, but also looking at what's happening for that particular patient, from a fluid management point of view and gas exchange. So a very new thing for the OR, something that we're not that familiar with in the operating room environment, but now definitely has approval to be used in the operating theatre environment, is EIT. And looking at the Pulma Vista in particular from Dräger, and wondering whether or not it can actually help improve anaesthesia and anaesthesia decision making. We're not going to dive into this too deeply, but the trials have been conducted. There are some really fantastic small studies out there with EIT guided PEEP, optimal PEEP finding as being the key outcome, and it comes out very positively in favour of using some impedance tomography as a way to find your optimal PEEP. A couple of studies that we can share with you actually really do clearly show and demonstrate that using PEEP guided by electrical impedance tomography will definitely help your patient's outcomes and improve finding that optimal PEEP. We'd like to hand you over now to Lynn, who will run through actually how to do a lung recruitment manoeuvre on an anaesthesia machine. In this particular case, it's a Perseus. So thank you for that, and over to you, Lynn.
Thanks, John. As you can see, this is a Perseus anaesthetic machine, and it has many great features for lung protective ventilation. It also has automated lung recruitment. In the settings area, we can pre-configure our ventilation defaults for each patient category based on their ideal body weight. Evidence says this should be between 6 to 8 mils per kilogram. Our PEEP should be set at 5 or above. These pre-configured defaults support decision making at the point of care beyond just our traditional flow and volume curves. Now I'll start a case. Here we have the parameter boxes set up to provide information to the anaesthetist about the anaesthetic and support low and minimal flow anaesthesia. The first box is the low flow wizard, It shows if the flow is adequate for the patient and will turn red if the flow is too low. The second parameter box is dynamic compliance. This is a trend, and you're looking to see if it moves in a gradual way or in a sudden change. When you intubate, the compliance will be around 50 to 60, but if the patient is then put into a head-down position, the compliance may drop to 35 or 40. Once it is below 35, it would be prudent for the anaesthetist to perform a lung recruitment manoeuvre. The next box is minute volume by CO2. If this is trending down, then this is also guidance to do a lung recruitment manoeuvre. Lastly, we have delta VT. This shows the inspired tidal volume and the expired tidal volume and the difference between the two. We'll show whether there's an airway leak, especially if you're using laryngeal masks. The econometer also supports the user and the hospital by showing the required flow for this individual patient. This will save the hospital money, as the lower the flow rate, the lower the amount of volatile agent being delivered, and so the lower the cost to the hospital. The lower the adequate flow for the patient, also the better for humidification, as the heated breathing system in the Perseus heats the fresh gas flow that's provided to the patient. This helps to maintain body temperature and ultimately may decrease the risk of post-operative pulmonary complications. When anaesthetising, it is best to work to the global recommendations of 6 to 8 mils per kilo of tidal volume and a PEEP between 4 to 6 millimetres of mercury, and limit the driving pressures. So now we have a patient that's head down, paralysed and intubated, and the compliance has dropped. This may also indicate that there could be post-operative atelectasis, as there is limited physical space for the lungs to expand and contract. So what do we do? It's possible to perform a lung recruitment procedure. This is under the Procedures button. There are 3 options. First is the inspiratory or expiratory hold. This is a handy, quick manoeuvre. Then there is one-step recruitment, which is similar to a Valsalva movement or a bag squeeze. It's very simple. There is not as much evidence supporting the clinical outcomes of this as there is for the multi-step recruitment, but it will help in patient gas exchange during the anaesthetic. You have full control of the pressure and the duration, and you can do this in any ventilation mode. Please remember, there is no ventilation happening while this procedure is occurring. So normally we have 30 millimetres of mercury for 30 seconds. And remember, once you start, it will not let you repeat it for another 30 seconds. If during the procedure you need to cancel, just touch the cancel button and confirm. However, it is possible at this stage to adjust your PEEP. So this is often used where you've previously done a recruitment manoeuvre and you would like to take your PEEP up. If you start the recruitment manoeuvre, it will open up the alveoli. You can press cancel and adjust your PEEP, and when the cancel is confirmed, your PEEP will be changed at the higher setting. This option is widely practiced in hospitals, and the turbine ventilator helps to keep the PEEP stable. Lastly, there's the multi-step recruitment. This has an inspired pressure maximum and a PEEP maximum. It keeps the driving pressure as low as possible within a difference of around 10 millimetres of mercury. Pressure and PEEP go up in a stepwise fashion. It is possible to set the delta pressure maybe around 15 or even lower, 12 millimetres of mercury. You can also set the number of breaths at the maximum pressure and the number of breaths per step as it goes up and down. The duration shows how long the procedure will start, and then we're ready. If required, once the procedure has started, it is possible to either cancel or ask it to descend now if the patient is reacting in a negative manner. The traditional way to find optimal PEEP is to look where the dynamic compliance has gone up and the PEEP has dropped off. This can then be used for the patient once the recruitment manoeuvre has been finished. The minute volume alarm may activate during the recruitment manoeuvre as the ventilation may not reach the set targeted volume. You don't need to swap ventilation modes during the procedure, as the machine will automatically swap to a pressure controlled mode and then back to the set mode when it finishes. Dräger anaesthetic machines transfer settings between the volume controlled and pressure controlled modes if the user switches between them during an anaesthetic. Another way to have a good look at the best lung recruitment ventilation for the patient is to use the analysis tool on the Infinity acute care monitoring. John will show you a picture of this as well. Ultimately, to determine the best settings for a complicated patient would be to use the Pulma Vista in the OR. We will look at this later in the webinar.
Thank you, Lynn. Fantastic explanation and a great example of how to perform an automated lung recruitment manoeuvre. If you have any particular questions on that, obviously reach out to your Dräger representative, and we'd love to be able to demonstrate that to you. Fantastic.
Yeah, thank you very much. So we have now talked about lung recruitment in the OR, coming from the OR to the intensive care environment. So I think one major difference we already mentioned is, of course, that in the OR we're mainly looking at more or less easily reversible atelectasis. However, in the intensive care environment, there's a magnitude of different reasons which might be causing atelectasis. So definitely the challenges here are quite big because we might have very different reasons which might be causing this atelectasis. So we have to look at very different strategies. Is this atelectasis even reversible in the first place, and what should we do? So talking about mechanical ventilation, we in the intensive care environment, of course, we are looking at the acute respiratory distress syndrome, which might be a consequence of ventilator-associated lung injury. So really, this is affecting 23% of all mechanically ventilated patients which are developing ARDS. Of course, we could even dive deeper and talk about COVID ARDS as well. But in general, ventilator-associated lung injury is a very important aspect in the development of ARDS and of lung injury in general. So what can we do to lower these numbers, to make sure that less patients are affected by ARDS? So when we look at the pathway of an average ICU patient, of course, there are different phases trying to prevent intubation in the first place. If this is not possible, protecting the lung, focusing on weaning, and lastly, also having the right steps after extubation to ensure extubation success. But today, in today's session, we really want to focus on the stabilization phase. So what can we do to protect the lung, to prevent ventilator-associated lung injury, and of course then also reduce the incidence of ARDS? So we're looking at a magnitude of different strategies. When we look at UIT here, we see that we could, of course, look at a pressure volume curve, which really shows you the mechanical behavior of the lung. When we look at this pressure volume curve, we see that we have zones of potential derecruitment and we have zones of potential overdistension. So these are really the two ends of the spectrum. So what we're trying to do is we're trying to ventilate our patients in this safe zone, in this green zone. And finding the right settings, the right pressures and the right volumes, that's what we're going to talk about today. At the same time, I think it's still clear priority number one is assuring oxygenation and CO2 removal with minimal invasiveness. We heard already about lung protective tidal volumes. What we also want to do is reduce stress and strain, finding optimal settings, stabilizing alveoli, finding a compromise between collapse and overdistension, and also, as one of the latest results of research, we want to reduce driving pressure. Maybe we dive in and start with the driving pressure. Here you can see this study from Marcelo Amato, which looked at driving pressure and the survival in ARDS. And in this analysis, he was looking at different combinations of driving pressure, so keeping the driving pressure similar, increasing driving pressure, or even lowering the driving pressure. This is what you see up here. And in his research, he could clearly see that a higher driving pressure was associated with a higher mortality. And you could find this, basically this threshold value around 15 millibar, which is deemed to be safe, a safe driving pressure value. In other literature, you might find the value for 14 millibar. So based on these results, we should aim at a driving pressure below 15 or below 14 millibar. And the driving pressure accompanies us also in other recent developments, because when we look at the mechanical power equation as well, we can see that the amount of energy that we are putting into the lung, which might cause potential harm, is also affected by the driving pressure itself. So really highlighting the importance not only to look at PEEP and tidal volumes, but also trying to lower the driving pressure, which is necessary to achieve a set tidal volume. What can be done to do this? How can we still achieve a certain tidal volume and potentially not change or increase the driving pressure? Of course, you see the answer is very likely, optimizing PEEP, optimizing end expiratory lung volume. So talking about lung recruitment. So recruitment maneuvers and outcome. Already in the 1990s, Lachmann postulated the open lung concept. I think everyone here knows the famous quote, "Open up the lung and keep the lung open." This is his basic principle. And I just wanted to show, there has been a lot of research looking into open lung strategies, the open lung concepts. You see here different studies from 1998 to 2016. Another meta-analysis also from 2017, which had the conclusion that the open lung strategy during mechanical ventilation could reduce mortality among patients with ARDS. So opening the lung, keeping the lung open. So let us have a look at another meta-analysis, really singling out the effect of lung recruitment maneuvers. So we are looking at lung recruitment, again, in patients with ARDS. And also in this meta-analysis, you can see very clearly a favor towards lung recruitment. However, and I think this is now we're slowly getting to the but. However, we can see that there seems to be a signal towards lower mortality, but the confidence in this finding is actually limited. And further trials are still required. So this was the status that we had in 2017. On this note, when we look at COVID-19 ventilation strategies, I think we can't have any educational webinar at the moment without at least mentioning COVID-19. In this nice overview paper from China from the April 2020, so really one of the first larger publications which are addressing strategies for patients with COVID-19. In this study, they of course also sharing lung protective ventilation strategies. So I think many of these things we have already mentioned before, limiting tidal volumes to 6 ml per kilogram, ideal or predicted body weight, looking at plateau pressures, optimizing FiO2, looking at optimizing PEEP with different tools that we will mention later as well, but specifically mentioning lung recruitment. And in this recommendation already stating that lung recruitment needs to be evaluated and should be executed for patients where the lung recruitment can restore aeration. So already in this recommendation stating lung recruitment should be performed only in patients that will benefit from a potential lung recruitment. But how do we know this? How can we find this out? We need to assess lung recruitability, and here they already were suggesting several tools, from using CT scan, EIT, so electrical impedance tomography, or ultrasound. So these are just a few tools that we can use to assess lung recruitability. Because when we don't do this, we see, of course, potentially very negative results. And this is why I wanted to have now the segue to the ART trial. In the ART trial, we were looking at the effect of lung recruitment and titrated PEEP versus a low PEEP strategy in mortality of patients with ARDS. You know, a very big trial with over 1,000 patients to really answer the question, you know, is lung recruitment the way to go? Is this beneficial for all patients? And of course, lung recruitment is only the first step. So really then also looking what's next, which PEEP should I set? So in this study, they had a protocol which looked very similar to this. They were starting with an initial lung recruitment, if you see here, actually going up to very, very high airway pressures. You see here even up to 50 millibar. So this stepwise lung recruitment followed by a decremental PEEP trial. And afterwards, the PEEP was set at, you know, at the ideal compliance. So we would have thought, or would have expected, a significant signal which shows us an improved outcome. However, when we looked at the results, we could see that the intervention arm, that really the intervention group, showed a higher mortality than the low PEEP group. I think this was a big surprise to everyone, which of course cast a big shadow over basically everything that I've just shared with you. So what does this mean? What does this mean? We see lung recruitment and titrated PEEP led to a higher mortality. So we can now ask the question, is the door closing on the open lung? Is this really still the way to go? So really to understand what might have caused this higher mortality, we need to look a little bit at the study design. And if you see right here, you can see that actually the different groups were assigned by randomization. So you can see right here in the study protocol, it was not defined which patient would receive a lung recruitment maneuver. So it was not, there was no link between lung recruitability or an assessment of recruitability and actually being chosen for the recruitment group. So when we look at these results, actually, we can ask the question, is lung recruitment killing patients? I would say, is the door closing on the open lung? I would say not yet, because really, I mean, what this study data actually more clearly shows is that if you perform lung recruitment in a patient which is a non-responder, so which does not benefit from higher airway pressures, we are seeing a significant increase in mortality. And this is not just my opinion. This is something which has been stated, of course, also by some of the original authors in a letter to the editor. They found out by looking at the study data in more detail that actually the observed harm of the ART strategy seemed to be concentrated in those patients with null or negative recruitability. So really confirming everything that I've just said, that really it's showcasing for us really how important it is to assess whether or not a patient is a responder to a recruitment maneuver. So what was causing this higher mortality? What are side effects? What are possible adverse effects of lung recruitment? Of course, the most obvious side effect is barotrauma, so really damaging the alveoli, leading to structural damage, which might even lead to a pneumothorax. And really this process, of course, itself, this tissue damage, then later on could lead even to a cascade of inflammatory mediators, which leads to biotrauma, which is really just kicking off a potentially multi-organ failure all the way to death. So this is, of course, I would say the mechanical side of it, looking at the lung mechanics. At the same time, you also need to look at the cardiovascular system. As John rightfully said, both the lung and the heart, they share a cavity. They're both in the thorax. So, of course, by increasing airway pressures or pressures within the chest, we might have a possible circulatory depression. So this higher pressures might lead to reduced venous return and reduced left ventricular ejection. So which you can then see or monitor by a reduction in blood supply, lower arterial pressure, lower cardiac output, and even a decreased SpO2. So this is why it is so important to really make sure that we are using appropriate cardiovascular monitoring to see what is happening inside the lung and inside the chest or inside the heart of the patient. And this is why we have created this analysis tool in our Infinity Acute Care system. So what you can do is you can combine or you can link the ventilator to our monitor and to see both data on lung mechanics and arterial pressures or cardiovascular information at the same time to see, yes, maybe we are increasing the dynamic compliance, but that comes at a price, which might be then a negative reaction of the cardiovascular system. So with this tool, we can do lung recruitment safely by, of course, having a look at how is the cardiovascular system responding to be able to abort at any time. So maybe we can now head over to Craig to show us how this can be set up in the clinical setting.
One of the many benefits of doing recruitment manoeuvres on the Dräger Evita V800 in combination with the Infinity Acute Care system through Dräger's connected technology approach is that on the Infinity Acute Care system, whilst doing a recruitment manoeuvre, you can pull up what's called the analysis tool. What the analysis tool allows clinicians to do is see multiple parameters in one place. For this example, I've got a recruitment trend that I've set up specifically for this scenario. I've got heart rate, mean arterial pressure, SpO2, PEEP, PIP, P-mean, end tidal CO2, dynamic compliance, and tidal volume expired. What this allows a clinician to do is see all the parameters in one place to see whether or not another parameter is being sacrificed. An example I might give is during a recruitment manoeuvre, a clinician can see straight away whether their mean arterial pressure has dropped due to the pressures of the ventilator being too high during the recruitment manoeuvre. They can also see whether the PIP has been set accordingly or the PEEP being set accordingly in relation to the dynamic compliance. SpO2 is another great parameter to look at during a recruitment manoeuvre. Has the SpO2 increased during or post the recruitment manoeuvre, indicating what could be a very successful recruitment manoeuvre in itself.
Thank you, Craig. So as we can see, we want to do lung recruitment safely to make sure we only do this in patients which are responding well. This is one way to ensure your patient safety when doing lung recruitment. So we talked about already, let's say, the landscape. We talked about the open lung concept. Now let's really dive a little deeper. How can we do lung recruitment with our ventilators? And here you can see a big overview of all the different strategies. When we think about lung recruitment, we can look at sustained inflation. So one typical example could be this 40x40 maneuver. We can look at intermittent size or even intermittent increases in PEEP. What we can do is incremental or decremental PEEP trials. So we are increasing inspiratory pressure and PEEP in parallel, so keeping the driving pressure constant. We can also just increase the inspiratory pressure, leaving the PEEP the same, or vice versa. We are leaving the inspiratory pressure the same and increasing PEEP. And of course, all possible variations and combinations of everything that I've just mentioned to you. A very different approach is APRV, which is a ventilation mode, which is aimed at maximizing lung recruitment, at increasing the mean airway pressure. We will come to that later on. And of course, other things which we cannot cover today is, of course, prone positioning might be really considered as a recruitment maneuver, and variable mechanical ventilation as another interesting approach how to improve recruitment with as non-invasive strategies as possible. But when we look at lung recruitment, it's always important to see, and I mentioned this before, lung recruitment is only part one. If lung recruitment is not followed by an adjustment in PEEP or an optimization of settings, you will see that the initial recruitment will go away, because we have then the atelectasis, which is coming back and redeveloping over time. So it's very important, once we have recruited the lung, opened the lung, to keep the lung open, and this is done by PEEP. So again, even here, it's important to look at oxygenation and CO2 levels. So there are different ways how to set PEEP. I think we all know the ARDS net table. So simply setting PEEP according to FiO2, which is one way. Or when we look at decremental PEEP trials, we can then look at actually, again, at oxygenation. So see at which PEEP level that we have the highest oxygenation, looking at SpO2. We can look according to dynamic compliance, or we can look at something like Pomovista to have an image to see lung recruitment in real time, CT scans or X-rays, or we can also look at something like a low flow PV loop. And we're going to try to cover as many of these topics as possible today. Starting with PSI, I pulled out some studies from after 2000. Of course, PSI has been around already for quite a while. Nevertheless, we can see that PSI is still relevant even today. When you're wondering how many PSIs per minute, there is different literature which looks at recommending 1 PSI per minute or 0.5 PSIs per minute. This seems to be the general recommendation. And of course, getting the benefits of PSI, with mimicking really natural breathing, so to say, giving this one breath, which allows you to increase FRC to re-recruit potential areas within the lung, which is then leading to improved gas exchange, decreased respiratory drive, improved lung mechanics. So this is one of the benefits that can be achieved with PSI. When we look at our ventilators into the Evita V600 and V800, how can we set PSI? We talked about the impact of driving pressure. This was one of the first slides that we showed you. And keeping this in mind, the Dräger philosophy of doing PSI is by having an intermittent increase in PEEP in order to protect the lung and not to increase driving pressure.
Our PSI functionality is looking at an increase in PEEP while keeping the driving pressure constant.
You can see this actually in this image quite nicely. For these breaths right here, you can see a higher PEEP level. And then after this PSI, we go down back to the baseline PEEP.
Keeping the driving pressure stable.
So when we look at this, we can turn PSI on and off. We can select how many PSIs per minute do we want to do. And when you are within a PSI cycle, you can select for how many breaths do you want the PSI to be, and how big is our increase in PEEP. So as you can see, we are trying to keep the driving pressure constant. We are only increasing the PEEP level to not have an increase in driving pressure. I think this is a very important aspect. Another tool is to use the inspiration hold. So basically this long inflation maneuver, or the sustained inflation. I mean, when you look at current literature, I mean, I think there are various variations of the classic 40 by 40 maneuver. Now, I think when we look at literature, it's more and more common to do something like a 20 by 20 or 30 by 20, so 30 millibars for 20 seconds or 40 millibars for 20 seconds. Why are we looking at these longer timelines? Of course, we know that lung recruitment takes time. Lung recruitment is always a result of mean airway pressure and time. So this is why the timing of the inspiration hold is actually very important. And in the Dräger ventilators, really the timing of the inspiration hold is at your fingertips. Once you press and hold this button, you are in complete control. If you let go of the button, the inspiration hold will immediately be aborted. So this way, you are completely in charge and can make sure that you abort whenever necessary. The maximum time is 40 seconds. After this, we return back to ventilation.
Interestingly, this is also an option on the Perseus. It's not anywhere near as common, not discussed anywhere near as much in the operating theatre environment, but it is an option to have a manual inspiratory and a manual expiratory hold on the Perseus anesthesia device. It's certainly not as widely kind of thought of in the operating theatre environment, however.
Yeah, so as you can see here from some of the studies, of course, I mean, again, assessing the impact of such an aggressive maneuver. You can see down here in this graph, comparing non-responders to responders, and especially looking at the cardiovascular system. Actually, you can see that in a non-responder, the cardiac output might drop significantly, stroke volume might be dropping, mean airway pressure dropping. However, in a responder, you actually see that all these parameters seem to be stable. So really linking a little bit back to what we said initially, by looking at the cardiovascular monitoring, we can really make sure that we are aborting an unsuccessful recruitment maneuver just in time. To explain more on this, how to do this inspiration hold, we're going to head back to Craig to show us how it's done.
Thanks, Christian. I'm now going to display a sustained inflation or continuous descending pressure recruitment manoeuvre, otherwise known as a 40-40. This is an inspiratory hold for a maximum of 40 seconds. A sustained inflation recruitment manoeuvre, otherwise known as an inspiratory hold of 40-40, can improve a patient's gas exchange and end expiratory lung volume. We recommend setting the driving pressure relatively to the patient's P plat. This can be done in modes such as PC-SIMV by increasing the driving pressure. In this case, I'm going to increase the P inspired to 30 millibars. Then, by simply selecting the manual inspiratory hold button and holding it for 40 seconds, as I can see on the screen, it counts up. By doing so, I've now completed a sustained inflation manoeuvre on the Avita V800 ventilator.
Thank you, Craig. So now we know how to do a sustained inflation maneuver. Coming to the next recruitment tool that we already mentioned before, which is the low flow inflation maneuver. I mean, this has been already first proposed, as the super syringe method, where we are trying to create a quasi-static picture of the lung, showing us how does the lung behave under different volumes and different pressures. So really very gradually increasing the volume inside the lung and to detect the mechanical properties of this lung. Of course, the super syringe method is something which is very cumbersome. So we try to automate this with our devices, with our integrated low flow PV maneuver. With this low flow PV maneuver, we are if we are trying to mimic this procedure, of course, we still have a very low flow that we can actually set manually to then create this PV loop of the lung. Remember our picture from the beginning, so you can see here what we're trying to understand is the hysteresis of this particular patient, because every patient has a unique PV loop, and actually this PV loop is even dependent on ventilation history, previous recruitment maneuvers, previous PEEP levels. So you will actually see that this low flow PV loop is highly dependent on where is the lung at this moment in time. Where are we in the weaning process? Where are we in the lung recruitment process? So trying to open the lung and see then, of course, how it's behaving on the closing side. So looking at this, clearly, when we are determining these different pressure levels, of course, this gives us an indication where should I set my PEEP. If I'm trying to prevent de-recruitment, the PEEP, for instance, in this picture, should be at least set at 4 millibars. But in order to set it at this level, I need to make sure that the lung has previously been opened. So really giving us a very good understanding of the different opening and closing pressures in our patient. There are actually 3 points of interest in this pressure volume curve. We have the lower inflection point, the upper inflection point, and the point of maximum curvature. And these 3 points we will be using to find optimal PEEP and to find the ideal tidal volume or inspiratory pressure settings. So, starting with the lower inflection point. Traditionally, it has been seen as the point where the lung is fully recruited. However, nowadays, actually, we might say that this is actually really just the start of recruitment. Then looking at the upper inflection point, this is then when, maybe going back to this curve, this is then, when we see this a typical beak, right? We see that higher airway pressures don't lead to an increase in volume anymore. So this is usually the zone of overdistension. So really, this is, of course, the traditional interpretation, and this should be the limit for our inspiratory pressure or plateau pressure, because we want to avoid or minimize overdistension. However, this might also just be the end of recruitment and only the start of overdistension. So a little bit blurring the lines here. And lastly, the point of maximum curvature, which is determined on the expiratory limb. So we see here, this is inspiration, right? We are increasing our volume and pressure, and then we see down here the expiratory limb again. So the point of maximum curvature shows us on the expiratory limb, really, when we see this increased loss in volume. So this might be then telling us when does the lung start to collapse again. So looking at the closing pressures of this lung. So when you are now you are determining these points, the idea could be to, of course, either set PEEP above the lower inflection point, or with the more recent interpretation, setting PEEP actually above or equal to the point of maximum curvature, and minimizing or limiting your inspiratory pressure to this upper inflection point. To explain you more how this is done, we will be looking at a video from Craig. Just one minor disclaimer, unfortunately, we were using a test lung. So you will be seeing something which looks like this. So please don't be irritated. This is what it would be looking like in a real patient. In our test lung, you see something which looks slightly different. So nevertheless, the process is still the same. Craig?
Thank you, Christian. Next, we'll have a look at an automated lung recruitment manoeuvre with the low-flow PV loop on the Avita V800. Low-flow PV loops on the Avita family serve as an automatic lung recruitment manoeuvre by slowly filling and emptying the lung with a low and constant flow. Only the elastic properties of the respiratory system are recorded. The virtual quasi-static pressure volume loop displays a good correlation with the static super syringe method, conveniently carried out with the same equipment at the bedside. The loop can be recorded for inspiration or inspiration and expiration. You can choose between inspiration only, low flow inflation, and a manoeuvre which comprises of both inflation and deflation. By setting the flow that is delivered during the inflation and also controlled during deflation at a sufficiently low level, the resistive pressure component can be neglected and virtually only the elastic properties are recorded. The initial pressure of the manoeuvre can be set between the current PEEP setting and 0, as you can see by P start. Because the low flow PV loop also acts as a lung recruitment manoeuvre, in order to maintain the positive effect of such a recruitment, it is necessary to apply at least the PEEP level that prevailed prior to the manoeuvre. To commence a low flow PV loop manoeuvre on the Avita V800, touch the procedures button, scroll across the tabs along the top, select low flow PV loop, and then select manoeuvre. In the low flow PV loop menu, I can see P start. As discussed before, it's best to do this not lower than your current PEEP. The P limit is the maximum pressure that will be delivered during the manoeuvre. Some clinicians will set this relative to the P max or slightly above. The low flow is in minutes or litres per minute, and be mindful that this also correlates to the time of the procedure. If I see the V limit, this is the maximum tidal volume to be delivered during the manoeuvre. Clinicians will normally do this double the tidal volume, so 11 to 12 mils per kilo. I'm going to do this at 250 mils, given that I'm using a test lung. Select Start, Inspired and Expired, and Confirm. Right now you can see in the volume and pressure graph, I've got a low flow PV loop. If I go now to reference, I can select the references that I might have previously had, or I can go to analysis. In analysis, I've got a cursor A and cursor B. By selecting cursor A and using my rotary knob, I can select the upper and lower inflection points. So right now, I'll select the lower inflection point, and by selecting cursor B, I can select the upper inflection point. Additionally, I can also select the point of maximum curvature. By doing so, I can see my pressures there, my pore, my volume, my dynamic and static compliance, and again, I can automatically straight away select a PEEP and tidal volume that will then go into the patient's ventilation mode going forward to adjust the settings. If I want to scroll through my previous low flow PV loops, I can select the reference button to scroll through. And that's how we complete a low flow PV loop.
Thank you, Craig. So now we learned how to perform a low flow PV loop and how to interpret the different points. So we're using these settings to then determine optimal PEEP and ideal inspiratory pressure or optimal tidal volume, depending on if we are in pressure controlled or volume controlled ventilation. So with this in mind, just one more topic I would really like to mention, what can we do with the ventilator, and that is really monitoring lung mechanics. The ventilator usually, gives us all the necessary information. We can look at the waveforms, we can look at flow, airway pressure, volume to really understand how is the patient and the ventilator interacting. However, there are several parameters which give us a very good indicator for lung recruitment. So when we are doing this kind of recruitment maneuvers, we want to monitor end inspiratory pressure, which is a surrogate for plateau pressure. We want to monitor PEEP, then monitoring tidal volume, and monitoring also the dynamic compliance. Especially tidal volume, dynamic compliance, they can then give us an indication, are we actually improving the compliance? Are we increasing the tidal volume? Because this is what we're trying to achieve with our recruitment maneuver. This is why you have actually the functionality to monitor all of these in real time on the ventilator itself, to really scroll back and then also make an informed decision. What is the ideal PEEP? What are the ideal ventilation parameters for this patient? But to explain this a little bit more, we're going to hand back to Craig.
Thanks, Christian. I'm now going to show you how to do an incremental recruitment manoeuvre on the AVITA V800. To perform an incremental PEEP recruitment manoeuvre or incremental PEEP and PEE-inspired recruitment manoeuvre on the AVITA V800, simply do so by selecting your PEEP, increasing it accordingly, and doing a stepwise approach until you get to the level of PEEP you want to achieve, and then a stepwise approach down. If you want to increase your PEEP and PEE-inspired at the same time for a recruitment manoeuvre, simply do so by selecting the link button. What this does is link the PEE-inspired and the PEEP so that when you increase one, the other automatically increases by the same millibars. As you can see here, I've increased my PEE-inspired and my PEEP. In my mini trends here, if I scroll back, you can see that I've previously completed a recruitment manoeuvre using a stepwise approach. The benefit of the recruitment trends is that they support reviewing of the recruitment manoeuvre and attempt to allow the clinician to optimize ventilation. They give a breath-by-breath trend of the PEEP, the tidal volume, and the dynamic compliance. You can manually use the cursor, as I've just demonstrated, to find the settings for the best compliance and find the settings for the best tidal volume.
Thank you. So now we've learned, I think, a lot of theory behind recruitments, potential outcome improvements. We then looked at different strategies, how to perform a recruitment maneuver, and lastly, also how to monitor recruitment maneuver, of course, on the one side on the ventilator and also together with the patient monitor. One last topic, at least I think we want to mention this, is of course to use airway pressure release ventilation. This is a completely different philosophy of ventilation, especially when we will be looking and focusing on the publications by Neda Habashi. So when we talk about airway pressure release ventilation, you see actually down here in this graph, really already the main philosophy. We are trying to increase the mean airway pressure. But at the same time, when you look at a normal breath, you know, we have these two areas where we might see lung injury, either, you know, with too low airway pressures, too low PEEP, which might cause atelectrauma, and at the same time, too high airway pressures, which might cause barotrauma or volutrauma. So the goal for APRV is to increase the mean airway pressure to allow spontaneous breathing throughout the entire cycle at this very high level of pressure. So think of APRV as a high-level CPAP. So the patient breathing on a high-level CPAP. But of course, we are very often looking at very critically ill patients which are not breathing by themselves. So if they are not breathing spontaneously, it's very important to look at both parameters, look at oxygenation and look at CO2 removal. Oxygenation means we need, of course, fresh tidal volume, fresh air coming into the lung. But I think we see, especially in APRV, we are not really concerned about oxygenation because these mean airway pressures, these high mean airway pressures, allow us to get oxygenation under control rather quickly. So the main focus is to make sure that we have stable blood gases, so looking at CO2 removal. So therefore, we have these short release times where we give the lung some time to wash out CO2. So we have a high CPAP level with short bursts where we are releasing CO2 and of course at the same time giving in new fresh gas. So maybe here from this publication from 2005 already from Neda Habashi, where you can see what I just explained once again. Basically, if this would have been the optimal or ideal PEEP, usually with our inspiratory pressure, we need to add volume for ventilation, and we are of course increasing potential cyclic damage, so cyclic opening and closing of the lung, which might of course increase the ventilator-associated lung injury. So therefore, it's a completely different strategy and philosophy of ventilation, where we are looking at very, very long I to E times. So really the inspiration to expiration time is usually 4 to 1, 6 to 1, 8 to 1, and these short release intervals are usually just a fraction of a second. Why just a fraction? Because we want to make sure that the lung and expiratory lung volume remains stable. So we want to stabilize the lung, stabilize the alveoli, only have a very short release of CO2 while maintaining maximum recruitment. And we can see in different literature that APRV does facilitate spontaneous breathing, which is then augmented with these short releases that I mentioned. It can reduce the need for sedatives, and it can also reduce the duration of mechanical ventilation, as well as days in the ICU. And it's really something that can even prevent the progression of lung injury in high-risk patients. So this is, of course, coming from literature. I think this right here is a very good example, which is an article, again, from Neda Habashi, which looked at data from 16 different studies, where he could show that the use of APRV might prevent ARDS. So when you look at this graph right here, you see this is the study population, and you see on the left the injury severity score. So the patient's mean injury severity score, so how sick are the patients? And the study population that were receiving APRV was actually from the upper quartile, so with a more significant lung damage. And those patients, when then looking at the incidence of ARDS, were in the lowest group of ARDS. So these rather sick patients were in the lowest group that actually developed ARDS and had the lowest in-hospital mortality. So if you want to learn more about APRV, again, a mode to maximize lung recruitment, please feel free to reach out. We're more than happy to explain the principles, how to use auto-release, also to stabilize the lung volume and to prevent potential de-recruitment. So we now talked about lung recruitment in the OR. We talked about lung recruitment in intensive care. We looked at different strategies. We also looked at the things to look out for. And we can already see that lung recruitment is definitely something which needs to be evaluated properly. One very promising tool is electrical impedance tomography. And this is what we're going to talk about in this last section of the lecture today. So image-guided lung protection, as we just discussed, we have various different tasks and goals of therapy. However, when we look at an ARDS patient, or in this case at a model of an ARDS patient, we can see a picture which looks something like this. In this CT scan, we see areas of the lung which are collapsed. This is area D. But at the same time, there might be areas of the lung which are experiencing overdistension. So therefore, actually, the remaining lung that is functioning normally might be a lot smaller than what originally anticipated. And this is what's called in the literature the baby lung. And between the baby lung and the collapsed regions of the lung, we have this area with cyclic opening and closing. So all these factors are impacting the potential outcome of our patients. For today, we will mainly focus on alveolar collapse, but of course, we also will be able to give you indicators for overdistension and even tidal recruitment. So when we look at lung recruitment in ARDS patients, this is a really a landmark study from Gattinoni from the year 2006, who looked at the different response of ARDS patients to lung recruitment. And I'm going to zoom in a little bit. And you can see in this picture up here, a CT scan at an airway pressure of 5 centimeters of water versus a scan at 45 centimeters of water. And if you compare left and right, you actually see that we are not opening up this consolidated tissue. I mean, you see maybe a minor improvement, but more or less the pictures and the amount of collapse is still very similar. However, what we see is when we look at the heart, that the heart is significantly compressed. So something we already talked about and something to clearly look out for. Now, when we use the same strategy for a different patient, we might be looking at something like this. So in this patient, suddenly we see again 5 centimeters of water versus 45 centimeters of water, and we see a huge improvement from left to right. So this is how you would see in a CT scan the difference between a non-responder and a potential responder to a recruitment maneuver. So it's already very clear that for these two different patients, we need two different strategies, and airway pressures should be adjusted individually. So how do we now know, is this patient actually benefiting from a recruitment maneuver, yes or no? So usually, I mean, the previous tools that we have were, of course, looking at a CT scan, but only really a series of CT scans could actually tell us really how is the patient responding to these different settings. And I think we can all agree that this is something which can be maybe done, in a study environment, but clearly not in clinical practice. But this is the kind of information that we would need. We change, a certain parameter and see how is the lung doing, just to understand, is this patient a responder or a non-responder? Which regions were opening up? Which ones did not? And of course, to answer the quest for the Holy Grail, which PEEP should I now set after the recruitment maneuver to both minimize de-recruitment and overdistension? So this is the situation that we're in. And even if we had this kind of, basically CT scan production line where you can send your patients through hundreds of CT scans, even then a CT scan would not give us a continuous information. It's only just a snapshot in time. So as you know, lung mechanics are dynamic. There's a frequent change in behavior. So therefore, we need something which is giving us more real-time information.
I don't think the surgeon would want you to send your patient off in the middle of surgery for a CT scan. Sure.
Yeah, I think there might be a conflict of interest there.
Sure, that's indicated.
Yeah. So when we look at the different modalities, how to monitor lung recruitment or how to monitor our patients, we can look at ventilation parameters, we can look at oximetry, capnography, blood gases, and X-ray or CT scan. But as you can see, each of those methods has certain advantages, also certain drawbacks. But what we are now talking about with electrical impedance tomography is the missing puzzle piece, something which really tries to bring together all the benefits from the different information. So we need regional continuous information at the bedside, non-invasive and radiation-free, to really use Pomovista 500, this electrical impedance tomography device, as a decision support tool. And I want to say very clearly, of course, Pomovista and EIT can never replace any of these other modalities. It is something which is completing the picture to give us the necessary information that we need right at the bedside or right at the table, right at the OR table, to make an informed decision on what might be the optimal settings for this patient. So actually, when we look at the application, we need to use an electrode belt, which we are placing around the patient's chest. I think this is something more common that you might all be familiar with. So we are placing an electrode belt with 16 electrodes around the chest. We are measuring the electrical resistance of the chest and can then generate these 2D images, which are showing us the distribution of tidal volume in real time. And we can do this from infants to adults. So in order to understand this imaging modality, let's start with something that you're familiar with. And we're going to compare CT and EIT. So one thing both CT and EIT have in common is the imaging projection. So we are looking at a caudocranial slice, more or less, through the chest. So this means when we are looking at it, the right lung is on the left and the left lung is on the right. In our images here, we're expecting to see the heart somewhere here and the spine down here. So when we are looking at these images, this is already something that CT and EIT have in common. And now in the next few slides, you will see that there are, of course, fundamental differences between CT and EIT. So let us start by looking at lung function. Electrical impedance tomography is a lung function monitor. So what are we expecting? When we're looking at a healthy lung, you can see this CT scan on the left. In a healthy lung, lung function, we all know this happens on an alveolar level. So in a healthy lung, we are expecting to see normal filling and emptying of alveoli. So something like this. This is a healthy lung. So on the left, we see a CT scan which tells us about air content. It gives us morphological information. So now how do we see pictures of lung function? And this is now a picture that we see generated by EIT, which shows us the distribution of tidal volume in real time. This picture shows us where does the tidal volume go. We see right here the chest, we see actually the electrodes, right here those white dots, and we see different colors. Black color means little to no change of air content, a dark blue, some change of air content, and white being the maximum change of air content. So this is usually the regions with the best lung compliance are actually in white, because air takes the path of least resistance. So therefore we see in these regions the most tidal volume going to those compartments with the highest compliance. So this is the very fundamental difference between CT and EIT. CT shows you air content. It's a static picture, just tells you how much air is in there. And on the right, we see change of air content. So telling us where does the tidal volume go. So as a fundamental difference, if you see black color doesn't mean that this part of the lung has no air inside. Black color only means that there is no change of air content. So usually when we are looking at a mechanically ventilated patient, the change of air content comes from tidal breathing. So this image shows us the distribution of tidal volume in real time. And what we can do is we can analyze this picture. So this is a tidal image, which shows us a map of the distribution of tidal volume. So this map tells me exactly for this particular breath, where did the tidal volume go? And you can see once again the same colors, and we can quantify it. In a healthy patient, we are expecting to see 10 to 15% of the tidal volume both going to the ventral and the dorsal part of the lung. So to put this into numbers, if your patient is currently receiving 400 ml of tidal volume and on the machine you are reading 10%, then this means that 40 milliliters of those 400 are going into this particular region, just to help you understand what those pictures mean. Another difference between CT and EIT is the sensitivity region. Actually, a CT scan is only looking at a very thin slice through the chest. With electrical impedance tomography, we are looking at a much broader lung volume. This lung volume is usually roughly 1/3 of the entire lung volume. So depending on where you place the electrode belt, you will see a different picture. And this 2D picture is representing a larger lung volume. So just keep in mind the position of the belt is influencing the information that you get. This is why we are recommending to place the belt on intercostal space 5, because this way you have the most dependent and most non-dependent parts of the lung in the same picture. So intercostal space 5 is the place to go. One more advice, also make sure the belt is not placed too low, because as you all know, the lower we go, then we are more and more looking at the diaphragm. So please keep in mind, if the belt is placed too low, you might see some artifacts caused by the diaphragm. So take home message, place the belt in intercostal space 5 and you will get a reliable image. So we were now looking at a healthy patient. Now let's have a look at a dorsal collapse. We see this very clearly in the CT scan. Now, what does this mean for our alveolus? Of course, a collapsed alveolus will be deflated. We don't expect to see any tidal volume going into this part of the lung. And this is actually exactly what we can see with electrical impedance tomography. Remember before how the picture looked like? We had a blue picture, which was very evenly distributed. Now we suddenly see a lot of black color. So this black color tells us there's a lack of ventilation. There's no change of air content. So the tidal volume is not going into this dorsal region. It's mainly going to the ventral and mid-ventral part, which is also highlighted in the percentage. Only 3% of the tidal volume is going into this dark spot. So this is how we can already understand EIT images. When you're looking at a tidal image, try to look for a lack of ventilation. And this lack of ventilation might give you already an indicator there's something off, there's something wrong with the distribution of ventilation. And then in the next few slides, we will tell you how to find out what might be the cause for this lack of ventilation. So following a simple example, let's start with this. This is real patient data from a patient with pneumonia. When you look at this image, you can already see that there's a very uneven distribution. You see this is the right lung, this is the left lung. Almost the entire tidal volume, 82% of the tidal volume is going to the left lung. This is not physiological. So by looking at this picture, we can immediately already see there's something off with the distribution of ventilation. In this case, they decided to perform a recruitment maneuver. The patient started coughing and mucus was removed. And suddenly you can see this. You see an improvement of ventilation in region number 1 and region number 3. So you can immediately see, while you're performing a recruitment maneuver, is the patient responding yes or no? To have this immediate feedback, is my therapeutic intervention actually achieving what I wanted to achieve? And if we now continue even more, 4 hours after recruitment, we can see that the distribution of ventilation has improved even more. So going back to this, these 2 slides, just as a very, very easy rule of thumb to really understand what is going on inside the patient's thorax, it's highly beneficial to look at a before and an after picture. You have the before and the after picture, and it tells you always immediately, are you achieving what you want to achieve? So in this case, recruiting this part of the lung. And here we can see, yes, there's a positive response from here to here. There's more blue color in the region number 1 and 3, and also the percentage has increased. So this is a good indicator that we're looking at a positive response to this recruitment maneuver. The same principle can be, of course, also used for patient proning. The picture could be before proning, after proning, before an increase in PEEP, after increase in PEEP. So you get the idea. Looking at a before and after picture allows you to assess what is happening inside the patient's thorax. So to have a more standardized approach, we developed this concept which we call image-guided lung protection. So what we need to do is we do a therapeutic maneuver, either or a diagnostic maneuver, either with the ventilator or, of course, also with the anesthesia machine. Then we have a look at POMOVista 500 to see how did the patient respond to this. And then with this information, we can then try to treat the previously unseen. We can find the right settings or the right strategy for this patient. The approach that I'll be sharing with you is based on the Costa approach. So where we are looking at changes and interpretation of lung compliance, we can actually look at regional lung compliance. All we need to do is perform a diagnostic PEEP trial. So this is one example how this PEEP trial could look like, keeping a constant driving pressure, recruiting stepwise the lung, followed by a decremental PEEP trial. And if you look at the time needed, if you're doing this, this can be done in less than 10 minutes. So we mentioned this over and over again, but it's very, very important to check recruitability before you are increasing airway pressures too high. Make sure that the patient is actually responding to the recruitment maneuver. We saw this on the patient monitor. We saw this also in different mechanical parameters. But now let's look at an EIT picture. So this is the POMOVista screen, which allows us to identify responders to a recruitment maneuver. Let us begin in the middle. Here you see the global impedance curve, which shows us the electrical resistance of the chest. You see inspiration, expiration, inspiration, expiration. So something which looks very similar to a compressed volume curve. And then we see something happening, followed by a decremental PEEP trial. So what has happened? We have down here, if we're connecting the Pomovista to either anesthesia device or a ventilator, we can import the information on PEEP, inspiratory pressures, and tidal volumes. So what we can actually see is that there is an increase in PEEP and PIP. So in order to really compare the status of the lung breath by breath, we allow you to look at tidal images. So this tidal image represents the distribution of tidal volume of one entire breath. So you see here, this is the reference cursor. This is our initial condition. Then you see the comparison cursor right here, right in the middle of the recruitment maneuver. So when you look at this graph right here, or this table right here, it tells you in this recruitment maneuver, we have increased PEEP from 5 to 14 and also increased the inspiratory pressure. So what has happened now inside the patient's chest? Let's begin by looking at the start. First of all, we see in the initial condition, there was a lack of ventilation in region number 4. You don't see any blue color. If you look at the percentage, only 3% of the tidal volume is going into region number 4. So after this recruitment maneuver, you can then see that suddenly there is now blue color in this dorsal part. And also the percentage has improved from 3% to 16%. So by comparing this image with this image, just on a visual basis, you can already see there's a big difference from here to here. And we see that especially in the dorsal part, which is most prone to atelectasis in a supine patient, we can see this significant improvement in region number 4. Also, this picture showing us in blue color a gain of ventilation. So this is a clear sign that we're looking at a responder to a recruitment maneuver. So this, I've done this here in this example with a very big increase. EIT is very sensitive, and we can already see even in a minor PEEP increase. If you just go from a PEEP of 5 to a PEEP of 7 or to a PEEP of 8, you can already see is the distribution of tidal volume changing, yes or no. So giving you a very early indicator. So now that we have seen that this patient is a responder, we do a decremental PEEP trial to find out what is the ideal PEEP. It's not an easy question to answer, and it's of course a strong debate around this. But for the sake of this presentation, the ideal PEEP should be high enough to prevent de-recruitment, at the same time low enough to minimize overdistension. So we're going to try to find the right compromise. So with Pomovista, we can now look beneath the surface. We can try to see the previously unseen. Before we could only look at global respiratory mechanics, and now with electrical impedance tomography, we can look underneath, we can look at overdistension, cyclic opening and closing, and regional lung collapse. So remember the colors on this picture that we had in the beginning. We're going to come back to this. So here you can see the result of an automated PEEP trial analysis. So the Pomovista can automatically analyze this PEEP trial by assigning analysis sections right here. So for each PEEP level, we are assigning an analysis section. So in this trial, we've gone to a PEEP of 14, 12, 10, 8, and 6. And we are looking at the corresponding tidal image. So showing us the distribution of tidal volume for these individual PEEP levels. So what we can see is by lowering the PEEP from 14 to 6, if you look down here, especially in region at a PEEP of 8, you can already see the onset of de-recruitment. So a PEEP of 8 is not high enough to keep this part of the lung open. And now when we look at this third row, you can see a map of regional lung compliance. So regional lung compliance. So in this map, we can see in orange color a compliance loss towards higher airway pressures, which is associated with overdistension. And in this white color, we can see a compliance loss towards lower airway pressures, which is associated with collapse. So in orange, overdistension, and in white, collapse. And we can see this now in real time. So at a PEEP of 14, yes, the lung seems to be completely open, but it comes at a price, and it is a significant amount of overdistension. So one strategy now could be we recruit the lung. Now we find the best compromise. So in order to help find the compromise between overdistension and collapse, we are showing you the amount of overdistension and collapse in this graph right here. So one potential strategy could be to go for the intersection and to then find the best compromise between overdistension and collapse. And if you see this here, the yellow color associated with cyclic opening and closing, we don't have the time to really dive deep into this. So we're going to focus really on this intersection between the overdistension and collapse curve, because this is really the optimized PEEP that we can then go back and either set on the Evita or of course set on the anesthesia machine. Keeping in mind that, of course, before we set this, it's important to re-recruit the lung. We looked at this. We need to set the PEEP in an open lung. So don't forget to re-recruit the lung afterwards. And there were several studies already looking at this EIT-guided PEEP selection. You will actually find a lot of literature on this. But when we're comparing EIT-guided PEEP, for instance, even with a low-flow PV loop-guided PEEP, in ARDS patients, we can see significant improvements in the EIT group, improved oxygenation, better compliance, lower driving pressure, and a higher weaning success rate. So already very promising. When we look at hospital survival rate, even here, you see the graph, EIT group versus control group. The survival rate seemed to be higher in the EIT group. Unfortunately, this is not statistically significant, so it's only an early indicator, but of course, very promising. And since we mentioned COVID-19 in particular, remember COVID-19, we want to assess recruitability. This is exactly what is being done. This is a short review of some very recent literature that is using EIT for COVID patients. There it's being used for PEEP titration, looking at positioning changes, detecting early signs of pneumothorax. This was one of the potential side effects of lung recruitment. And of course, to evaluate lung recruitability. So really, for those COVID patients, one of the main applications of EIT. So we covered a lot of different topics. I know 2 hours, I mean, we could only scratch the surface. And as you see, you know, we try to really cover as much ground as possible. And also we try to give you an unbiased and balanced view on different recruitment strategies, also looking at critical literature. But of course, when we now want to summarize our findings, lung recruitment, is it for every patient?
No.
No.
No. Certainly not in the OR. We certainly need to consider it, I think, more often in the OR than we probably currently do in general practice, but it's certainly not for every patient. And, you know, we have some, you know, really great tools on the screen of modern anesthesia devices and patient monitoring to help assist with that decision-making, which is key.
Yeah. So therefore, lung recruitment should be individualized only for patients who are considered a responder, looking at the cardiovascular system, looking at the lung mechanics, looking at EIT. We need to be aware of the side effects, so barotrauma, pneumothorax, circulatory depression. This is why we need close monitoring.
Yep, and certainly there are some contraindications. You know, there's no evidence in neonates, not much, if any, in pediatrics. And of course, you know, anybody with intracranial pressure or severe lung damage, we certainly don't. And there's no recommendations around actually doing any recruitment in those types of patients.
Yeah, also unstable circulatory system. I mean, the list of potential contraindications is, of course, also long. So after lung recruitment, very important, of course, setting individualized PEEP to then prevent de-recruitment.
Definitely.
And I think now we've learned that actually Pomovista can be used to assess recruitability, both in the OR and in the ICU. It should be used as a decision support tool. One topic we did not really dive into is transpulmonary pressure measurement. Another, I would say, very exciting field because transpulmonary pressure can also tell us about PEEP setting, tell us about lung recruitment, tell us about the condition of the patient. The good thing is, also with Dräger devices, you are able to monitor esophageal pressure. So if you're interested in transpulmonary pressure measurement and transpulmonary pressure guided PEEP setting, this can be done with Pomovista as well.
That's another webinar.
That's another webinar, exactly. So another topic for another webinar. We couldn't squeeze this in as well. But if you're interested, of course, we are also here very happy to support you. So this is the summary. So now let's go to our questions and answers. And Craig will be reading out the questions that we have.
Thank you, Christian. As you said, we'll now be going to answering the questions submitted. We've got a few, so just bear with me as I read through them. So the first one is, what is the most efficient ventilator technology in anesthesia machines in terms of leak compensation, the Perseus, the turbine, or the piston in the Atlan?
It's a great question. The turbine probably can manage, a larger leak. The key is actually setting the appropriate fresh gas to ensure your patient has got a consistent supply of fresh anesthetic agent and oxygen in the circumstances of having a large leak. The turbine, has probably the ability to maybe be able to respond to larger leaks. Having said that, the piston, has a very large volume and can manage, really quite large leaks. So it's very, very minimal between the two, but I would probably suggest the Perseus has a slight advantage there.
Just before I read out the next question, just a reminder to everybody who's listening in, if you want to put a question, just submit it in your control panel there on the right-hand side. The next question that we've got is from earlier. What is the difference between predicted body weight and actual body weight?
Predicted body weight is I guess the ideal body weight, or there's a few different terminologies, but it was actually I guess determined or put together many years ago. There's a few studies involved in that. So, actual body weight can be very different for very many types of people. My ideal body weight's somewhere around 76 kilos. I haven't been 76 kilos since 1976. But my lungs don't change as I put on weight or as I lose weight is the key thing. So, somebody who's 170 centimeters tall has an ideal body weight, whether they are 100 kilos or whether they are 60 kilos. Because the size of your lungs and the size of your chest cavity and the positioning of your diaphragm doesn't significantly change when you're either put on weight or you lose weight. The key to ideal body weight is it's basically determining the size of your lungs and what is the optimal tidal volume for your lungs. I think it's been around since the 1930s.
Yeah. And there are several different formulas.
Many different
and there are different formulas. But in the Dräger devices, the formula is already integrated, so you don't need to do any math. You simply enter the height of the patient, and the device does the rest for you.
Exactly.
The next one is from Christian. It was about around the time that we were talking about low flow PV loops. Can you do this on the V500?
That is correct. Yes, you can do this on the Evita V500. That is possible.
I know.
Even you know.
And we have no more questions for the moment. So thank you everyone for attending today's webinar. We've just had one come in. Sorry, bear with me as it's scrolled down. We've just had two latecomers literally get in by the last minute. Is it recommended to apply recruitment manoeuvres in all anesthesia sessions, or is there a specific time frame of the operation which lung protection tools could become necessary?
Look, I think it's pretty commonly known that 90% of patients who have a tube put in their throat and are sedated and paralysed will have some form of atelectasis. Most of that's very, very easily recruitable and sometimes recruited on its own, either throughout the case or even shortly after the case is finished. Certainly, the longer the case, the more relevant recruitment becomes. The indicators are pretty simple, you know, a low SpO2, you know, poor FiO2, you know, not actually exchanging gas very effectively, and, you know, a significant decrease in the dynamic compliance of that particular patient. You know, a particular case where it's very relevant, you might say, would be where you've got a big belly full of CO2, the patient's been head down for a long, long time, you know, over 2 or 3 hours. You'll certainly get significant impact on the patient's dynamic compliance. There will definitely be some form of atelectasis, and that is always likely to be recruitable. But, you know, very, very short cases, you know, there's not a lot of evidence to suggest that that there will be, you know, positive outcomes improved by lung recruitment. But having said that, everything I think we've said today is that, you know, recruitment is definitely individualized per patient, and it definitely needs to be thought about, considered, and then decided upon on an individual case-by-case basis. And, you know, if you've got queries or concerns about whether your patient should be recruited, then that's, you know, ideally you're thinking in the right way straight away. So, you know, that's the key thing, to at least consider it.
Thank you, John. The next question is, how do we know a patient is a responder or is responding from a recruitment maneuver?
Yeah, I think we covered this now because there are various aspects to this. It really depends, of course, also on which tools you have available. In general, I think we highlighted the importance of monitoring. You can look at lung mechanics. Lung mechanics is one side of the coin. Looking at the heart is the other side of the coin. But actually, I mean, there are also other tools. You could use something like an ultrasound as well to look at lung recruitment. Of course, if you have other imaging, chest X-ray, CT scan can be used just to confirm de-recruitment or recruitment. But in general, how to determine a responder? What do you want to achieve with a lung recruitment maneuver? You're trying to recruit lung, so you want to increase the end expiratory lung volume. You want to improve the gas exchange. You want to improve lung mechanics.
Reduce driving pressure.
Reduce driving pressure. So basically, really, as soon as you see a significant improvement in any of these parameters, while, of course, always monitoring the heart closely, while the patient is coping with this well, then you are on your way, because this means you are actually able to reverse atelectasis one way or another. And you can see the effects usually in the improved gas exchange. You can take blood gases as well, just to confirm this. So there are various different ways. We didn't talk about this too much, maybe just a little side note. SpO2 values can help you also detect lung recruitment. However, only if you are following a cautious FiO2 approach.
Yeah.
If you're only using small concentrations of FiO2, because only then, if you're using low concentration of FiO2, will you be able to detect this recruitment and de-recruitment early on. If you are ventilating the patient at 100% FiO2 all the time, very likely you won't see any signal in the oxygen saturation whatsoever. So therefore, this is maybe another just a side comment. Another, I would say, a reason to use rather minimal FiO2 values.
Thank you, Christian. We'll go through the last two questions just in the interest of time, but the second last one is, I think, a little bit difficult to ask the question in terms of it's asking if recruitment is okay in pediatrics. I think we've been through quite a few different types of recruitment maneuvers on our devices, but yes, asking if it's okay on pediatric patients.
It's a very, it's a very valid question. I mean, it is also being done in pediatric patients. Of course, there's also evidence. I mean, if you look at, for instance, the use of EIT can be used in pediatrics, and there are also many publications that also try to answer this question. So lung recruitment in pediatrics can also be done. The evidence, however, in general in pediatric ventilation is always even more limited than in adult ventilation. So therefore, I mean, we don't even have a clear recommendation for adults. So there's also, of course, no clear recommendation for pediatric patients. But I would say if you are following basically the guidelines and basically what we have just shared with you, this is also something that can be done in pediatric patients. Yeah. And deep diving into even neonatal ventilation, there, of course, you're using high frequency oscillation. High frequency oscillation is very similar to other, recruitment approaches, trying to increase the mean airway pressure. So even in neonates, a lung recruitment is done, but again, in a slightly different way.
Yeah, and certainly, there's even less evidence intraoperatively for pediatric and neonatal lung recruitment. So, follow the guidelines, check with your KOLs, with your peers, and of course use even extra special caution, I would say, and very, very, high vigilance on your monitoring would be the guidance.
The last question is a few questions in itself. The question starts with, I would like to know your approach for COVID pneumonia patients in terms of recruitment manoeuvres, and how would you apply the PEEP. It does ask about considering a lung recruitment manoeuvre if there's a chest drain and a pneumothorax, but I think that's a very specific case there to that patient. And also we have to be mindful that, we're tailoring our recruitment procedures to the patient and the different phenotypes of COVID, but I'll let you answer that one, Christian.
Yeah. No, but let me just quickly answer this, maybe starting even with the chest drains and pneumothorax. Of course, if the patient already has pneumothorax, you want extra caution. I've seen some very interesting cases myself, and of course also in literature, that again, EIT, electrical pulse tomography, can help you navigate these very, very difficult waters to really make sure that, the pressure is not too high, not too low, seeing even early indicators of a pneumothorax. So EIT might be one answer here. In general, I was citing some literature, but there's a lot more actually. If you look into COVID-19 and lung recruitment, there are different phenotypes, but even this is currently under debate. I would say let's stick to what we know, and we have a huge chunk of knowledge on classical ARDS. So not even talk about COVID ARDS. I think many of the things that we learned in typical ARDS or non-COVID ARDS can be applied to COVID ARDS. So similarly, making sure that you assess recruitability before you really do an aggressive maneuver. And we will see actually a very similar picture. Some patients will benefit highly from a recruitment maneuver, others not at all. So even for COVID patients, you have both sides of the coin. And I hope that we gave you the tools to really decide what might be the right strategy for this patient. We definitely cannot give you a general answer because it doesn't exist. The clear answer, if you want one very clear answer, we need individualized therapy and individualized recruitment.
Right. All right, so I think we'll end it there. The last questions, if any more come through, we'll endeavour to try and answer those and get them back to you. But in the interest of time, we'll close up this evening's webinar. So thank you everyone for attending today's webinar. Following today's webinar, we have a very brief survey which will pop up, so your feedback would be greatly appreciated. Otherwise, on behalf of all of us here at Dräger, we thank you for joining us. Stay safe and have a great evening.
Thank you very much.
Thanks for your time, guys.
Stay safe. Take care.
Be good, guys. See ya.
Bye-bye.
Thanks, Gerald.